first presenter. My name is Dr. Sarah Sitati. I am a pediatric ophthalmologist at Kenyatta National Hospital, and I'm also the chairperson of the Rupee Working Group of Kenya. Rupee is a topic that's close to my heart because it's an important cause of childhood blindness. So we are going to proceed and let Dr. Oscar Onyango do a brief introduction of himself. Dr. Oscar.
Hello, everybody. My name is Dr. Oscar Onyango, retinal specialist at Kenyatta National Hospital. And yeah, we shall take you through an overview of retinopathy of prematurity and discuss a few aspects of treatment. And yeah, discuss pros and cons of those aspects of treatment. We look forward to an educational afternoon. Yeah, thanks.
Okay, thank you, Dr. Oscar. So we are going to proceed with my presentation. I'm going to be speaking just as an overview of retinopathy of prematurity. And before I give this talk, I'd like to acknowledge Dr. Lucy Jambi, who's also a pediatric ophthalmologist and senior lecturer at University of Nairobi, who helped me to prepare this presentation. This is the outline that the presentation will take. We'll do a brief background of ROP, how it occurs, how we stage ROP, what are the risk factors, how do we look for it, or how do we screen for ROP, how do we treat it, and then finally the prevention. What you'll notice that the treatment, Dr. Oscar Onyango will go into more details about the treatment, but we'll just go briefly over it. On the other side of the slide, as you can see, is a picture of the anatomy of the eye. This picture is here to help us basically locate ourselves, because retinopathy of prematurity is a condition that affects the retina of the eye, and more so these blood vessels that you can see running on the surface of the retina. They are the ones which cause the pathology. So if we go briefly into the background, who discovered ROP, or retinopathy of prematurity? This entity was first described in 1942, and currently it accounts for about 19% of childhood blindness. It was discovered specifically in babies who were born prematurely, yeah, and formed a sort of epidemic in the UK and the US in the 1940s and 50s. Later on, apart from prematurity, they identified oxygen as a major factor that was important in causing ROP. And so after that discovery, there was an attempt to reduce the amount of oxygen given to premature babies so that you can reduce the amount of blindness that was being caused by this condition. But the result of that was that, yes, there was a fall in the incidence of ROP and ROP blindness, but there was an increase in mortality of the premature babies. We know that premature babies have poorly developed lungs and usually need oxygen to be able to survive for the first few weeks of life. In the 1970s and 80s, we started seeing another increase of ROP as more and more smaller babies survived. Kenyatta National Hospital had a feature on, we survived, I think, a 900-gram baby last year, and their departure from the hospital was a fanfare. But these are the kind of babies that are surviving more and more here. And so we are starting to see more and more children presenting with retinopathy of prematurity. How does ROP develop? As you remember, we had talked about how oxygen was discovered as an important factor in the development of ROP. When babies are born and they are born prematurely, they need oxygen. So when the oxygen is given to them, it affects the blood vessels of the retina or of the eye and puts the eye into a hyperoxic state. This hyperoxic state causes a decrease in vascular endothelial growth factor. And when this VEGF increases, the vessels regress and stop growing suddenly. So this is not the problem. But when the VEGF production is stopped, the eye responds, yeah, that there is ischemia going on, blood vessels are not growing, so please produce more VEGF. And when more VEGF is produced, instead of reinstating the normal the normal progression or growing of vessels, it causes abnormal blood vessels to develop. And that is what causes retinopathy of prematurity. This abnormal vessel development is the root cause of ROP. So when we look at retinopathy of prematurity, the only way you can diagnose it is by looking at the retina of the baby. There is no way that you will see ROP just by examining the baby with a torch. The eyes usually look normal on the outside, but all the trouble is happening on the inside. And so we need to look at the retina of the baby and specifically the blood vessels and how their growth pattern is. ROP is staged into 5 stages. The last stage is not indicated here, but we are going to see it a bit later. The stages start from the stage 1 is the mildest stage, and then from stage 5 is the most severe stage. So in stage 1, what we usually see is just that there is a line showing that blood vessels were growing, but they stopped suddenly, yeah? And we see what we call a demarcation line in the retina. Sometimes it is not so obvious. What we just see is that there is a sudden place where it has vessels and then a region where there is absolutely no vessels at all. And we call that stage 1. You can differentiate, there's an avascular retina and the vascular retina. When we go to stage 2, something called a ridge starts developing between the 2 zones. And this ridge is actually whitish as presented in this picture, and it separates the vascular and avascular areas of the retina. And this ridge appears whitish, yeah, and it is the point at which the blood vessels stop growing. When we go further from there, we go into stage 3. Now on stage 3, the first thing that happens is that the ridge becomes thicker, and then you start seeing some blood vessels growing on the ridge. And this ridge becomes so thick that it starts pulling on the blood vessels which are on the vascular part of the retina. So sometimes you can even notice some lifting during the examination, some lifting of the blood vessels as they come to join this ridge. And we call that the fibrovascular proliferation. This is stage 3. Now, when you reach stage 3, you are starting to enter the serious stages of ROP. Stage 4, you remember we talked about how this ridge can pull on the vessels and cause it to start lifting. Now, when we enter stage 4, it actually lifts off the retina. Yeah, the retina lifts and detaches from the rest of the eye. So in stage 4, we have retinal detachment, but this is partial retinal detachment, not the whole eye is affected. Retinal detachment in this picture is indicated by this brownish zone. The retina, this grayish zone, the retina actually lifts with the blood vessels that are on it. So this reddish area is the normal retina, and the grayish area that you can see here indicates a lifting of the retina together with the blood vessels that were attached on it. By the time we reach stage 4, we are losing the fight, yeah? We prefer that no children go into stage 4, because at this point, then you require surgery to treat this. Stage 5, which is not drawn here, is when you have now the whole retina lifting. because of this abnormal fibrovascular proliferation. So the whole retina separates from the eye and lifts. What you usually see is children come with a white reflex in the eye, and that white reflex, some people think it's a cataract, but actually it's not. The retina has detached and actually come to touch the front part of the eye. That is where it is visible. That is the worst stage of ROP, and that is the stage where we declare a child is blind. In the staging of retinopathy of prematurity, we also have an entity called plus disease. Now here, we just try to we try to quantify more or less subjectively the tortuosity of the blood vessels in the retina. Because if you look at the retinal blood vessels in like stage 1, most of them run a straight course, more or less. They are a little curvy, but they are not tortuous. They run a straight course. Now, when you come to plus disease, you find that the vessels become very tortuous and very engorged. So everything looks, all the vessels look swollen, and they become very tortuous in their path. So plus disease is also a serious thing, because you might have plus disease with no ridge, as we have seen from these other stages, yeah? But plus disease in itself is an indication for treatment, because when we leave it like that, it can progress just from plus disease to retinal detachment within a few days. And we have a term for that. It's called aggressive posterior retinopathy of prematurity, or APROP as the abbreviation. So once we decide on what stage the ROP is, yeah, we also quantify the disease according to the what we call zones of the retina. The yellow circle that you see here is the optic nerve of the retina, and these are blood vessels that are flowing out from the optic nerve going into the periphery of the retina. So we usually represent this with a circular diagram representing each eye. In fact, many times if you see we have done ROP screening, you'll see the drawings of these circles on the patient's files. The center is the optic nerve here. So basically we have three zones, zone 1, zone 2, and zone 3, starting from the inner going outwards up to the periphery. Zone 1 is the region that is closest to the optic nerve. And the reason why these zones are important is that diseases when the ROP is in zone 1, it is usually more severe, yeah? When it's in zone 2, we can say it's moderate, and zone 3, we are usually not very worried unless it is a high stage of ROP. So any disease in zone 1 is usually considered, you need to monitor carefully it carefully, because it usually presents the more severe forms of ROP. It means this child is developing ROP quite early in life. The rest of the retina has not developed, and usually will need a number of treatments before the vessels grow out all the way to the third zone, or to zone 3. What are the risk factors for developing ROP? The single most important risk factor is gestational age, yeah? If you were to pin one risk factor, it is gestational age. Prematurity is defined in pediatrics by any child who is born below 37 weeks. The risk for ROP is usually around 32 weeks, those born below 32 weeks. And right now we are surviving even 24 weekers and 26 weekers. So these are the children who are at highest risk of developing ROP. The second most important risk factor is the birth weight, yeah? So birth weight, irrespective of gestational age, has also been found to be an important risk factor. So the smaller the baby and the younger the baby, the higher the risk. The third risk factor is oxygen. So as we said, premature babies need oxygen in order to survive. So what we do, we really must find a balance between life and blindness, okay? And I think a lot of research has been done on the fact. So we don't reduce the oxygen so much that we increase the mortality, but we don't give 100% oxygen because it causes blindness, yeah? The mothers will be very happy to have their preemie survive, but when you explain to them that they have a lifelong disability, then it becomes a problem. So there's a balance of the oxygen. Yeah, the recommendation right now is we try to give at least 94 to 97% oxygen rather than give 100% oxygen. The other risk factors we have are those babies who are just sick babies. They need a lot of procedures and manipulations in the neonatal unit. They have anemia, they need transfusions, they have sepsis. They are the group we call the sick baby. Yeah, these ones are likely to develop retinopathy of prematurity as well. Other risk factors that we have that have been mentioned, prenatal steroids, this is a controversial one. Some studies have noted it to be actually helpful in reducing ROP, while some studies have blamed it for the higher incidence of ROP in babies. Maternal hypotension and hypertension have both been identified as risk factors. So here lie your mothers with preeclampsia, eclampsia, and so forth. And then multiple pregnancies. I think this one is a little obvious because most mothers with multiple pregnancies don't make it to, the babies don't make it to term. And so it's a high risk for prematurity. Therefore, it's a high risk for retinopathy of prematurity as well. So who do we screen for ROP and when do we screen? So we go back to, we cannot detect ROP with a torch exam. You need to look at the retina of the baby's eye. So that means that the eye has to be dilated and a special instrument used by the ophthalmologist, usually an indirect ophthalmoscope is used to look in the eye. We have national guidelines which have helped us to decide who to screen and when to screen. And our guidelines recommend that we screen all infants who are born 1,500 grams or less, or any who are born 32 weeks or less. So if the baby has any one of the two risk factors, then we go ahead and add them to the list for screening for ROP. The other thing that we must mention is that we have babies who are outliers. There are babies who are heavier than 1,500 grams or bigger than 32 weeks, but they are sick babies. So these are babies like you will find who have cardiac conditions in the NICU, babies who have hypoxic ischemic encephalopathy, and several other conditions where babies will need oxygen maybe for long periods of time, or they have respiratory distress syndrome and keep getting apneic attacks. So these are babies who are outliers, and we usually examine them for ROP as well. And this is usually in consultation with the pediatrician. So it may be difficult to pick the outliers, but if you work well with the pediatrician, then they'll be able to tell you, please screen that baby. That baby has been unstable during their stay here for whatever reason or the other. When do we screen? We say 4 to 6 weeks postnatal, and the rule basically is the younger they are, the more time we give them, yeah? So we usually screen when they arrive at around 30 to 31 weeks, because this is when ROP usually develops. But if we are going to go by a rule of thumb, the rule is that we screen when they're at least 1 month of age. all those factors that we are talking about in the development of ROP, the production of the VEGF, and then the suppression, and then, you know, the reactivation and the abnormal blood vessel development, these don't happen overnight. Yeah, these are things that are happening from birth. So when you examine the babies immediately after birth, these processes are still going on, and you might say the child is okay, and yet a few weeks later, they develop the problem. So this has been properly researched, and the rule of thumb is that at least within 30 days of birth, we have to carry out an eye exam for any baby who fits the above criteria that has been mentioned. How do we screen? You can see this picture here. It makes some people very queasy, yeah, because it just looks like these premature babies are usually quite delicate. Yeah, they don't like to be disturbed. They don't respond well to manipulations and procedures. And so you find that sometimes screening can be difficult for them. So what we usually do, the first step is to dilate the eye. Yeah, we usually use some what we call cocktail eye drops, which are a mixture of different dilating drops. And these ones, they help the eye to dilate so that we can be able to visualize the retina at the back. Without dilating, you cannot see ROP. Yeah. Encourage the parents to leave the room. Some parents insist on sitting and watching, but as you can see from the manipulation on the picture there, most parents will not be able to to withstand. And also the baby cries during examination, and so this might be difficult for the mother or the parents to watch. If the parents are not leaving, you can use a barrier to avoid onlookers. You know, like sometimes in our NBUs, we have several mothers sitting in a room. So you can either ask them to leave or use a barrier if it is possible. Glucose or sucrose can be used to feed the baby pre-exam. This is just to soothe the baby, but this should only be done in consultation with the pediatrician. You don't want to destabilize the baby's glucose levels for an ROP exam. Please consult before you do this, but it has been found to act as a good soother and to help your exam be easier. We instill local anesthetic drops just before the exam, just to make the child more comfortable, and do a swaddle. So swaddle has two functions of comfort for the baby and to help keep the arms away from the examination site. And then if you have you can support the head so that the baby does not move a lot. The less the baby moves, the faster the examination gets finished. Second, then we instill a speculum. This is usually a wire device that you put inside the eye to separate the eyelids. And it looks very uncomfortable. The thing with the speculum is usually it stretches out the eyelids, and this makes the baby cry. But it's not particularly painful. Yeah. Then we use what we call a scleral indenter. If you look at the picture on your right, you'll see that like a stick-like object that the doctor is holding, a transparent object. It can be glass or plastic or metal. So this is used to depress the eye so that you can be able to see all sections of the retina adequately and be able to detect any retinopathy of prematurity. And finally, we use an indirect ophthalmoscope, which is usually placed on the ophthalmologist's head and uses it together with a 28 diopter lens, which enables us to visualize the retina. How often do we screen? Depending on the stage of ROP, we'll find the more serious babies or those who have undergone treatment, will screen them more frequently, about weekly. But generally, we do the examinations 2 to 3 weekly for the children. I would like to say that most cases of ROP actually regress without treatment, but there are those which need a close follow-up, and those who have had treatment, we follow them up more frequently so that if there is any relapse, we can catch it early enough. When do we stop screening? So you can imagine the baby was born at 27 weeks. We started screening 4 weeks after birth, which was at 31 weeks. And then every time maybe we say there was no ROP, we'll see in 2 weeks. There was no ROP, we'll see in 2 weeks. So when does this 2-week cycle continue? Because we can continue it forever until the child is 4 years. But we actually stop at 44 weeks. Yeah. So if the child does not develop any ROP, the baby is at least 44 weeks. Yeah. Then we stop the screening. The other reason we can stop screening is when the retina is fully vascularized. You'll find many of our mothers are not so sure of their dates, yeah, and so you may not be able to rely completely on the gestational age to make that decision. So as long as the retina is fully vascularized, then we can stop ROP screening. And if the child has developed ROP, we follow them up until the ROP completely regresses. For some babies, this may mean follow-up even up to around 10 months, 11 months of age, yeah? But what I have found is that mothers, once you explain to them, they're usually quite motivated and they keep bringing their child to the clinic for follow-up. So how do we treat retinopathy of prematurity? So anything with stage 3 or above stage 3 or with plus disease, we have to treat, okay? And there are different ways we can treat. Yeah, most of these procedures can be done on the bedside in the neonatal unit, or they can be done in theater if it is available. So for the focal therapies, we have 3 major ones: cryotherapy, laser therapy, and anti-VEGF therapy. Anti-VEGF is an injection that you give directly into the eye. So once the drug goes into the eye, it calms down the blood vessels. For laser, we do this laser in the avascular zones of the retina, just to stop the blood vessels from progressing, to stop the retinopathy of prematurity from progressing. Cryotherapy is a treatment that's not done much anymore. It was done a lot in the 70s and 80s, but discovered that children, yes, it would clear the retinopathy of prematurity, but they would develop several complications later on in life, like high refractive errors, which means children would need very thick glasses to see and things like that. When we go to surgery, we do surgery when we're in stage 4 and stage 5. Remember what we're talking about, how stage 1, we have a line, stage 2, we have a ridge, and then stage 3, now we have the ridge becoming thicker and vascular proliferation on it. But in stage 4, if you look at this diagram at the top, there's a line there. This is when the retina starts to detach, yeah? This cannot be sorted out by any focal therapy. It needs surgery. Stage 5, you have a completely detached retina. This will require surgery. So by the time we are going to surgery, we have failed the baby, basically. We prefer that we catch the ROP before it goes to an advanced stage, because the truth is most surgical treatments have poor prognosis. Yeah, we may save the sight of the baby, but even then the vision is usually poor, and then some of them don't respond to surgery. Yeah, so you can have the retina remaining detached even after surgery. For prevention of ROP, the points of care, I think these are highly recommended. And we need to do pain control, oxygen monitoring, infection control, nutritional support, temperature control, and supportive care like positioning and kangaroo care. Please note that most premature babies need almost lifelong follow-up with the pediatric ophthalmologist. If they developed ROP that was treated, they will definitely need lifelong follow-up with the pediatric ophthalmologist. So premature babies have a higher chance of getting refractive errors, especially short-sightedness or myopia, squints or strabismus. Following ROP or ROP treatment, they may have low vision and may need special care like reading aids to read, special schools, and things like that. They may develop amblyopia, which is basically means that you've lost the connections between the eye and the brain. So while the eye may appear normal, it is not seeing. Then they can also develop glaucoma, which is high pressures in the eye. And these are babies also you'll find some premature babies grow up with neurological damage, and they need review by the ophthalmologists in addition to the pediatrician and neurologist. So basically premature babies, you'll find most of them, they're under multidisciplinary care. And it is important not to forget the ophthalmologist in this group. So in summary, ROP blindness is both preventable and treatable. And we usually, as an ophthalmologist, yes, we go to see, we do the actual examination, but usually we rely on pediatricians, yeah, to call us to review the babies. In Kenyatta Hospital, the screening is ongoing, and the registrars are in the neonatal unit every week to identify babies who need to be screened for ROP, and then the eye examinations are carried out. The treatments are carried out either in the NBU or they're carried out in the eye theater, and usually we will do injections for the ROP that we find in KNH. If we need laser treatment, then usually we go on into theater to do that as well. So the treatments are available. Even a few of our county hospitals, if they don't have a laser treatment, they will have at least the injections, and they can be able to give to treat ROP. I'd like to end by saying that this was not a problem that we were seeing a lot, yeah, until maybe 4 or 5 years ago, when blind babies started presenting to the pediatric eye clinic. And they come at the age of 5 months or 6 months with stage 5 ROP. And it is very difficult to tell a mother that her baby will never see for the rest of their lives, you know, that your baby is blind. And so I'd like to urge all of us, when we have that opportunity, please advise the mothers that their eyes must be screened in order to prevent this preventable blindness, cause of childhood blindness. Thank you. I think I'll allow Dr. Oscar now to proceed with his talk. So he's going to go over a few things as well, and then discuss more on the treatment of retinopathy of prematurity.
Thank you very much, Sarah. That was quite a detailed overview. Remember, our aim today afternoon is to inform us, all of us, I know we are different professions behind the different specialties, of the importance of screening for retinopathy of prematurity. And our pediatric colleagues are doing a good job now keeping them alive. So there's no excuse for any pediatrician or ophthalmologist, for that matter, not to know something about ROP and to always consult when they're not sure. So I'll just probably go through several slides, which Sarah has already mentioned, but I'll emphasize more on the treatment modalities towards the end. I think Sarah talked about when premature, the ROP, when the retina starts development. I think that was from around 4 months, starts at the optic disc area. And by the 8th month, we expect the blood vessels to reach the end of the nasal retina by 10 months, which is 40 weeks on the temporal side. Classification, Sarah went over that pretty well. Staging, Sarah went over that pretty well. You do realize in the eye we use a lot of pictures, keeps us entertained, and nobody will fall asleep. Now, talking about different forms of classification, this was the old classification, okay? And we currently use what is called type 1 and type 2 disease. We discussed the pre-threshold term there. Type 1 disease is when you need to treat. Type 2 disease, you observe. It's important to note that majority of ROP, as Sarah mentioned, does not need treatment. So we're not here to spell doom, okay? Probably out of 10, you'll treat one, even out of 15, you might treat one. So it's not that common a treatment that we do, but we do have to screen. Okay, now going straight, I think Sarah alluded to the hyperoxic phase. I would like to still overemphasize this in terms of the concept of the pink baby, which I think our neonatal colleagues would talk more about, whereby you want to see a pink baby. The more the oxygen, the better for everybody. That's the belief. And this is when you're causing more problems, because you're causing vasodilation and vasodilation of the developing retina. These are pictures we do with our fundus phones, and you can see tufts of blood vessels there. You can see a ridge here, a line here. So you're forming ROP at a very early stage. These are not normal findings. The optic disc is just here. Yeah, we do a lot of pictures with our phones now. It's a phone app that we use, and that we can train anybody to do that. You cannot screen for ROP with the direct ophthalmoscope. It's good to emphasize that. You will not see. You'll see 5 degrees. We're looking at 20, 30, 40 degrees. You will not be seeing anything significant, maybe the disc only. Then as a hypoxic retina stimulates the VEGF factors, the insulin-like factor, platelet-derived growth factor, etc. You have overproduction of all this, which leads to abnormal vascular growth. Again, these are pictures from the retina. You can see normal blood vessels reaching somewhere here. Then this tortuosity starts, and it starts lifting there, and it comes out of place at this particular area, and you end up with a detached retina. Mechanisms for anti-VEGF. So the treatments I'll discuss are 2. Antivascular endothelial growth factor injections and laser. Those are the 2 standard forms of treatment. Surgery, as Sarah mentioned, is a salvage procedure. In fact, when we teach our residents, by the time you're talking of surgery, any cases we get of stage 5 or stage 4 and 5, we inform the ministry, the head of ophthalmology, Dr. Gishangi, to follow up whichever hospital the child was born, while screening was not done. So far, I only know of one court case that's going on, one of the private hospitals where somebody was sued for not having screened properly on time several years back. But surgery is not a treatment option, so I'm not discussing surgery. That's a salvage procedure. You can reattach the retina, but you're talking about motion, navigation, or vision. You've missed the boat. So mechanisms of anti-VEGF, we're talking about 2 forms. We have the antibody, the full antibody, that's Avastin, that's a trade name. Bevacizumab is the molecule, or ranibizumab, which trades at Lucentis, or there's a new name, I'm forgetting that other new name. They bind to the various forms of VEGF. Pegaptanib is not commonly used. And when talking about retinal laser, we have pros and we have cons. Okay, many studies, which I will not go to here, have given us the success rates of laser. It's localized ocular treatment. You don't have systemic side effects, except depending on the type, on how you do your laser. I've done both with local anesthetic eye drops. We've done both a bit of sedation. We've done under general anesthesia. What you find is when you do it under local anesthetic eye drops, there's still quite a lot of pain. As you see, there's a tachycardia, heart rates go over 250 or thereabouts. Whoever is monitoring for you the vitals, most of the time the neonatologist or the pediatric anesthesia person is not very amused with you, because they know you're inflicting pain, and we are told some of this pain is carried forward into later development. I don't know if you get angry children out of this, but the pediatricians don't want the child as comfortable as possible during this. So those are some of the side effects that can be related there. Now the cons, it's destructive. You saw a few pictures from Sarah earlier on how the laser looks like. So we destroy the peripheral retina. If you destroy peripheral retina, you reduce the visual field. You also end up with high myopia, more short-sightedness, okay? I've alluded to the anesthesia bit. It's time consuming, stressful to the neonate. Costly infrastructure. Laser machines cost about 3 million Kenya shillings, thereabout. The good thing is the former provincial hospitals all got a laser machine that is used for the diabetes and ROP screening. It's the same type of laser machine. So if you don't have anything, you can't stop giving treatment because of this concept. You will give treatment. You'd rather have someone who's myopic and wearing glasses or has visual field defects, but is able to function, has 20/20 vision with a reduced visual field. Laser technique, remember, you have to position yourself. The way you position the lens, you saw a picture of how we do the screening, how we wear the ophthalmoscope. It's exactly the same setup for doing the laser. Okay, we depress, there's a way we press the eye, we try and bring the laser beam, the laser bands as close as possible to each other, because the aim is to cover as wide an area as possible. Swaddling the baby, local anesthetic eye drops. One private hospital I know has pacifiers. You put a bit of 50% dextrose and the child sucks that as you proceed with the laser. You can still use a wooden spatula, put sterile gauze on it with some sucrose, and that still works. You must have a monitor. Remember, these children are easily prone to apneas. I've had bradycardia episodes also, actually. And you need to know what is going on systemically. You can be doing very good eye treatment and end up with a blue baby, so to speak, and end up with other complications. The machine, we say, is the laser is delivered by laser indirect ophthalmoscope. 20 diopter loop is highly magnified. You see a smaller area, but it's more magnified. 28 and 30 diopters is what we tend to use. Again, no direct ophthalmoscope is needed here. This is what laser bands look like. This is when they're fresh. We try and bring them as close as possible to each other, all along there. And this, we talk about the depressor. You notice a bulge here. This is the depression. You're pressing here. But as you're pressing here, you notice bleeding is occurring because the blood vessels are highly friable. So you need to laser and minimize this as much as possible. But sometimes it's inevitable because of the nature of the aggressive retinopathy of prematurity. Bringing laser bands anterior to the aura. This is at the end, just behind the iris. If you hit in front of the aura, you're hitting the ciliary body, which produces the aqueous humor. Usually end up with hypotony, a smaller eyeball, uveitis, can even hit the lens, get cataract. Along the ciliary nerves also, that gives a lot of pain. That's 9 o'clock and 3 o'clock position. We warn parents about what happens post-treatment, what to expect. It's very important. Sarah had mentioned asking the parents to leave. I believe there's someone in the audience here who I will not mention who wanted to watch the baby being examined and ran out of the room backwards because it was very scary to them. We warn you right from before that this is what the examination is, and we tell you thereafter what to expect. Yeah, redness, swelling of the lids slightly. Most of this clear, from experience of they clear within 3 days, worst 5 days at most, but they are no harm, they're not harmful. It's just the effects of the lid speculum and the indentation. Follow-up post-laser, now depending on the zone of the disease, 1 week or 2 weeks, depending. If there's no regression, you need to add more laser. If it's anterior, posterior retinopathy of prematurity cases, okay, you have to review earlier. You cannot give it a week because you might go back after 1 week and you find the retina is detached. ROP is very, very aggressive, very unforgiving. You see it today, you miss out a diagnosis, or you decide to give it a 1 week review. You come back after 1 week, what was stage 2 with plus has gone to stage 4A, you know, and you're talking legal suits probably. Regression signs after doing laser, okay, those are the kind of things you see. Less hemorrhages on the retina, less traction. There's less plus disease. We talk about feeder vessels, okay. Sarah already talked about tortuosity, etc. on features of plus disease. This was as a study just to highlight. This is what made us start using antivascular endothelial growth factors for ROP. Bevacizumab, it's an acronym there, okay. And the dose we give is 0.625 in 0.025 mils. Now, this is a very small amount. We normally, in adults, we give 0.05 mils, like in bleeding cases, diabetes, etc. But if you look at the body mass of the child and all, lots of questions have been raised about this dose, especially for bevacizumab, because it's a whole antibody molecule. And for this study, they followed the children up to gestational age 54 weeks. And what was found was using anti-VEGF, that's Avastin, had a major effect for zone 1 and not zone 2 disease. Okay, the more posterior the disease, the more helpful it was. But this was extrapolated further to consider that the more posterior the disease, the closer you are to the disc, the less the vascularized retina you have. Anti-VEGF comes in handy because you do not destroy, you do not ablate peripheral retina. You can buy more retina, as I normally say, with giving anti-VEGF. You can give anti-VEGF now. The effects last 4 weeks, 6 weeks or so. Even if you have to do a repeat, you've developed more retina and you can laser a smaller peripheral area. Okay. This is incidentally, Avastin, this bevacizumab is used off-label. It's used for cancer of the colon, I think, renal cancer, etc. We just found that it works also well in the eye. It was being used for age-related macular degeneration, and it was also tried in the eye with that study, and it was an eye-opening study, and it worked well. So this is what is used specifically for the eye, not off-label, specifically made for the eye. The smaller molecule, high recurrence rate occurs. We've seen it also here, whereby we inject now after 3 or 4 weeks to find the retina is starting to lift, but the blood vessels have progressed probably from zone 1 into zone 2 anterior, or from zone 2 partially into zone 3. Now the issue is zone 3 disease has not been classified so much as to what to do. But if you have a bare area, you'll always have this belief that there's a possibility of neovascularization occurring in that area 5 years down the line, 8 years down the line. So we tend to laser the periphery only. You see, very peripheral doesn't cause much harm. Okay. In terms of comparing anti-VEGF versus laser, it's pretty tricky. The numbers are always small. You're looking at 20 eyes, 30 eyes, 40 eyes. And in terms of medication dosages, studies have looked at different quantities to give. Remember I said we give 0.625. Between 0.25 to 1.25 of the Avastin has also been reported to work, even as low as 0.031. But remember, the volume, this has to be made specifically for the eye. The amount of volume you're giving, this has to be calculated specifically for ROP. And it's been tried at lab level, but has not been actively used in clinical practice. Similarly to ranibizumab. Okay. Anti-VEGF time, yeah, we do follow-ups to ensure the retina has reached, the blood vessels have reached the periphery. That's what I was saying. So in terms of, if you have an avascular retina in zone 3, you'll consider laser depending on how much vascularity you see. Okay, so anti-VEGF, the pros and the cons. This is very fast. Anti-VEGF takes you like 5 minutes or something like that to do. Laser normally takes almost 30 minutes or so. Less stress to the infant, happens very fast, no systemic issues, non-destructive, time-consuming, less myopia as opposed to the laser. Systemic effects are not known. This has been looked at. We've discussed this. We're part of the Retinopathy of Prematurity work group of Kenya. We've had meetings with the Commonwealth guys. And neurodevelopmental stories have been asked, complications related to anti-VEGF. Of course, remember, they go systemic. And there's a possibility of suppressing organ development. But that's one of the risks. So expect smaller livers or smaller kidneys. So far, it has not happened. And neurodevelopmental issues can also occur based on the prematurity itself. But no clear study has given a total contraindication to systemic effects of anti-VEGF leading to a particular complication. So we still give it, we discuss with the parents, we inform them, the Dr. Google is there, they also look, and they ask and we tell them, this is the best for your baby because of ABC, the zoning, etc. And they tend to buy what we say. I've not had a case that declined injection and went for laser instead because of the destructive nature of the laser. Then of course, ocular risk. Anytime we inject the eye directly, you have to clean the eye properly, risk of infection is there, delayed vascularization, and then long-term follow-up. Remember I was talking about going up to beyond week 54. Anti-VEGF, similar setup. Maybe the only thing that we add there, you must have sterile gloves. Everything is sterile. The small speculum, the forceps. This has to be sterile complete, as opposed to laser where there's a light beam going to the eye. We inject, these are very big measurements for us, huge, 1 to 1.5 millimeters. Posterior to we measure the limbus and we point direct. I actually go up to 2 sometimes, depends on the technique used. But the checking for retinal perfusion can be done post the injection. You do a fundoscopy, a quick one, just to confirm your pulsations of the vein at the disc. Follow-up 1 to 4 days after injection. This is mainly to look if there are any signs of infection happening, but actively it's weekly. You're looking every week, you're trying to see if there's active ROP, is there regression or not? And then you're going to beyond 54 weeks to confirm how far have the blood vessels reached the retinal periphery. Okay, and again, if they never vascularized, you'll be able to tell because the blood vessels taper off and they just disappear into the substance of the retina, and it's a gray area left there. It will be advisable to do laser. Take-home points, you consider anti-VEGF for zone 1 and anterior posterior. The more posterior the disease, the high likelihood anti-VEGF will work better, even if you don't have laser machine. ROP may recur and may need secondary treatment. I've talked about that. With anti-VEGF, much longer treatment is required. Still unknown long-term systemic effects. We've used anti-VEGF in the eye probably certainly over 10 or 11 years. And so far, so good. We need to overcome our fears. I like using this slide. This fellow is chasing away the elephants from a shamba. There's no picture what happened after though. But there's a belief that he survived. And we are doing this. We are doing everything we can to make sure premature babies see 20/20 vision as much as possible. I think with that, I am, oh yes, coming to this is a work group, a few members of the work group. It is said to go far, you need to climb onto the shoulders of your giants. We have Rila, Warrior, and Gasheri there. Then in the background, okay, we have these are the youngest in the group maybe, and Sitari, of course, there. We hope there are people behind us who also climb onto our shoulders. So we climbed here, then the guys climbed above. This is Jambi, she's a pediatric ophthalmologist, works together with Sarah. And Sarah alluded to this, the guidelines. We came up with this. It was a joint effort, ministry, etc. And we've shared our guidelines internationally. You can find these online many places. And even we guided, I think, to Zambia, Zimbabwe, Nigeria, Tanzania. This is 2018. It's not it's a guide to work with. It's online, you can get it. Wherever you are, you can look through the pros and cons, whichever method you use, when to start screening, how to screen, it's all there. Okay, very easy to read. And ROP screening is teamwork. I think Dr. Sarah started alluded to this too. You can't, eye care is just one aspect of it. You know, we have so many different aspects that make this child in the middle see and develop into a fully grown adult who will be productive. So thank you. I think with that, I'm done. But over to you, Sarah.
Okay, thank you, Dr. Oscar, for your presentation. I hope you have understood. There was a lot of jargon there, but he went through the two main forms of treatment of retinopathy of prematurity. So I think if you see people doing treatment, at least you have a basic idea of what is going on. Yeah. To add to his presentation is that treatment is usually successful. And the difference of it is when you have a patient who you see, you know her baby had stage 3 ROP, and it had plus disease and was developing very fast, and you did the injection and the baby survived. And then she tells you she's in a group with another premature mother whose eyes, the baby's eyes were never screened, and the baby's at the same age and that baby is blind. Yeah. So there's a difference when we do treatment early. Yeah. Then we stop this blindness from occurring. So I think we can go now to the Q&A. There's a personal question here from Geoffrey Rotich. I think this one you can consult us further. There are several causes of blindness, and we are not sure what is it that caused your father's blindness, but he will need further reevaluation to be able to answer this question. Okay, from Felicitas, the question is that, so all premature babies are candidates for ROP screening? Very good question. So prematurity, we usually start defining it from 37 weeks and below. But for ROP screening, we start at 32 weeks. So yes, anyone who is below 32 weeks, born below 32 weeks, must have an eye exam done, okay? This baby should not be missed if they are born before 32 weeks or less than 1,500 grams. I'd like to put this question to Oscar from Salima. What is the follow-up period after the neonate receives bevacizumab in KNH eye clinic? In your clinical experience, what are the common side effects experienced by this group of babies?
Thank you, Salima. We do follow-ups, like I mentioned, between the first to 4 days, you're looking at the eye just to make sure there's no infected process. But after that, it's weekly to confirm that the retinopathy of prematurity is regressing, it's reversing, and the blood vessels are developing normally. And on the average, bevacizumab lasts longer in the eye than the smaller molecule ranibizumab. So you're looking at 4 to 6 weeks of maximum effect of that particular medication. In terms of when do we stop, I mentioned going up to gestational age 54. So we correct, there's a way we calculate what you're born with and how we add that up to make sure by the time we are sending you over to the pediatric ophthalmologist, for example, myself as a retina specialist, I will do the follow-ups annually. Once I'm happy with the vascularization of the retina, I send to the pediatric ophthalmologist. I'm happy the structure is very normal. And if I notice there is a bit of vascularity in the periphery, I'll do laser. So to answer your question, up to week 54 is appropriate. And in terms of side effects, systemically, like I mentioned, we've not seen any. Local side effects also have not seen any. But we have our eyes open and always watch as we do the weekly reviews for that.
Okay, thank you, Oscar. Another question here from Sabina. Why do some children develop, I think this is long-sightedness, at the age of around 3 years? So let me answer that as the pediatric ophthalmologist. There can be several reasons for this. The most common one being that they already had the problem and it went undetected. But around the age of 3 to 5 years is when children start becoming more active, especially with fine tasks like writing, coloring, and even with their play. Yeah. And so this may be the time when most people notice that they have vision problems. So it would be the best thing would have an evaluation done by an ophthalmologist who can be able to identify what was the reason of the long-sightedness. I think this was a non-Rupee related question, yeah, but it was a good one. I think one more question for Oscar. What percentage of the premature babies don't respond to treatment? Or is the treatment 100% successful among all premature babies?
Very good. As long as the screening is done on time. Sarah mentioned starting off screening from 4 weeks. Depend. If the very small ones, 24 weeks or 26 weeks, sometimes you can start at 6 weeks. Remember, the child has to be stable enough to be examined to have a fundoscopy finding. So sometimes you can find the 600 gram, 500 gram babies, we don't start at 4, maybe at 5 weeks or so, because the children, you touch them like this, you have an apnea episode. Okay, so people don't like it very much whenever you cause such complications systemically. But the percentage of people who progress, if you start the screening early, it's very, very small screening. In fact, I can easily say there's no child who started treatment on time who progressed to retinal detachment. That one I can say 100%. None. The cases we see that have progressed at late screening or no screening done at all, we're doing the first screening and the child is 4, 6 months old, 7 months old or so. Yeah, so that's why timely screening is a take-home message I can say from this. If there's anything you take away from this Rupee talk is screen 4 to 6 weeks after the child is born. Any child born less than 1,500 grams, any child born before 32 weeks gestation. And again, maybe another point to bring out is the pediatrician is a catchment person, if I can say. The pediatrician will guide. You know, the ophthalmologist doesn't go around into the neonatal units saying, I'm so and so, I've come to have a screening. I mean, guys look at you like a zombie, you know. But we work a lot with our pediatric colleagues, and they'll sensitize the nurses there. The babies belong so much to the nurses. You stress a baby, the nurse will not have you that liquid the next time. So as long as we work as a team, as I said earlier, and the pediatricians inform us on time, wherever you are, whichever part of Kenya you are, as long as you have a child who fits our criteria, keep us posted, learn how to do fundoscopy, talk to the ophthalmologist who's nearest you, who most likely is a young person who's taught how to use a fundus phone to do pictures, can use an Android phone to do fundus photography. They'll share it on WhatsApp. We get pictures from out of the country and asking us, what is this, how do we handle this? There's no excuse in this day and age really for progression of our people. There should not be. And late presentation also should not be there. Sarah, anything you wanted to add?
Thank you, Oscar. No, just that also I have never seen a baby who stage 3 or less that we have treated, stage 1 to 3 that we have treated and has not been successful. So treatment is actually 100% successful. Where we have problems is when we're in stage 4 or 5, and as we said, that is salvage therapy. We've basically missed the boat and failed the baby, but we try to salvage what we can at that point. So yes, treatment is successful. The next question, I think we'll do this as the last question. Can screening be done in any hospital? So the answer is yes. Screening can be done in any hospital with an ophthalmologist in it, yeah? So most of the pediatricians and neonatal nurses are quite motivated, especially once they know that there's someone who can screen the baby's eyes, and usually call on the ophthalmologist when they have babies to screen. So screening can be done in any hospital. We don't have that many ophthalmologists, but many of us go to several hospitals so that we can try to cover places that do not have an ophthalmologist on site. But screening can be done in any hospital where there's an ophthalmologist. Yeah. So I think I'd like us to end there.
The question about eye discharge, I don't know what you say about
yeah,
that.
there's a question about white discharge in the eye. Irene, if you can see me, personally, I can help you. We assess the baby and we can be able to determine what is the cause of that. But basically, it's a common problem in neonates. Yeah, around 4 to 6 weeks, it's common for them to have eye discharge. I think we have another question here for Oscar. Maybe you can help to answer this. What are the protocols you have in place to ensure you receive these neonates born below 1,500 grams at 4 weeks for screening from other facilities?
I think the catchment area is a pediatrician. That's why the RP work group is so big, and we're very big with the pediatricians. I see, I mean, like now we're screening even at Pumwani as part of what we do as a Kenyatta CSR. The problem sometimes is we get referrals from other hospitals late. Okay, so the Valley, as you know, Sarah, some of cases from there. But having the pediatrician have an idea about retinopathy of prematurity, and I believe the main in this audience, is the most important, because they'll get in touch with the closest ophthalmologist. I believe Sarah, you've had a case also in Kenyatta on the KPCC side, that someone got in touch with you and managed to correct a couple of things because the pediatrician got in touch with you. Yeah, as long as you get the pediatrician on board and they are aware, you'll be screening everyone on time. That's what I'd say.
Okay. Thank you for that answer. So I think we'll now close. The questions are coming. I keep saying it is the last question, and then other questions show up. Yeah. So I don't know. We'll have to close this at some point, but let's take a couple more questions. Can the Ceo Ophthalmologist screen for ROP? I think you mean Ophthalmic Clinical Officer, which is OCO. Yeah. So far, I do not know any who does. This is usually something that the ophthalmologists take charge of, and so I'm not sure. To be honest, I'm not sure it is part of their training. Yeah, but I can answer confidently that I know it's part of the ophthalmologist's training. And so most of them, by the time they leave the program, they are comfortable with screening for ROP.
Let me add something, Sarah. Regarding clinical officers, the training is there. They have an idea in terms of fundoscopies, but you need to be very comfortable with binocular indirect ophthalmoscopy. We're not talking about direct. We're not talking about monocular. What you wear, you're looking at achieving a stereoptic view of the retina. So if you can, you can have a Ceo Ophthalmologist who is pretty interested in this, we'll train them, we'll be able to tell them what to do. Yeah, that's possible. The only thing is, so far, I've not had any who's come to me or gone to you, Sarah, or gone to any of our colleagues asking to be shown how to use a binocular indirect ophthalmoscope. Because once they're happy with using it, it's easy to start off using it in adults before you go into children. Yeah, diabetic screening, etc. What is done at Lions and all this, when guys go for camps. Then once you're happy with that, then it's easy to transition into ROP screening. But we can easily show you what to do.
Okay, I'd like to add something onto this, that right now there are different methods of screening. Apart from the binocular indirect ophthalmoscope, something that's developing a lot now is telemedicine screening. And so if somebody has the equipment to take photos or to be able to take photos of the retina, yeah, like if they have a retinal camera that can be used on babies, even a technician or a nurse or a clinical officer, anybody can be taught how to use this instrument to take pictures and to identify abnormalities. And if there's any abnormality, then they can refer to where there's an ophthalmologist. So it's not like it's clear that it must be an ophthalmologist. Anybody can screen as long as they're trained to do so. Okay, I'd like to close.
It's good you mentioned that, Sarah, because the trend, when you widen the screening, the scope of screening, you might not have an ophthalmologist within 100 kilometers of you. But if you have an idea of doing fundoscopy, be it with a phone or whichever retinal camera you have, and you share that with the closest ophthalmologist, that will even spread the screening further. So I think that's a good take-home message also for the audience.
Yeah. I think we'll now close the talk for today. Thank you. We had good attendance and good questions, and we appreciate you taking your time out to listen to this important message, and we hope you have some good take-home points. And I'd also like to thank Dr. Oscar and KNH for organizing this CME for us. So you may now leave, and asante sana. Yeah.
Thank you.